Well, in this week's Cardiology News, we have a look at HDL number versus amount. Also a look at peripartum cardiomyopathy and risk factors for that, and an interesting study on intensive glucose control in ACS patients. So to begin with, we have an analysis from the Jupiter trial that was a statin versus placebo trial that looked at what are the predictors of risk with a focus on HDL. And so HDL cholesterol amount is the typical measure, but using NMR spectroscopy, they measured also particle number. And that's a way to determine size versus total amount versus number of HDL particles. And they found that the particle number was a better predictor of risk, and that held up after multivariate analysis, so that the higher HDL particle number, the lower the risk of developing cardiovascular disease. And so an intriguing new bit of data in this rather checkered history of HDL as to whether it will be predictive. So certainly something to keep our eye on. The second paper this month comes in JACC Heart Failure that is a very interesting look at peripartum cardiomyopathy. Now, this was a review of 4 million records, of which 535 patients were identified as having peripartum cardiomyopathy. So that's about just over 1 in 10,000 births that women had cardiomyopathy. Some of the known risk factors were seen, and that is age over 30, African American race, hypertension, developing preeclampsia or eclampsia during the birth, and multigestational status. Also, they saw a history of asthma and anemia were risk factors, and substance abuse and autoimmune disease were also risk factors for cardiomyopathy in the peripartum setting. And so I think a useful look in a huge number of births in patients as to which patients may be at slightly higher risk of developing peripartum cardiomyopathy. And finally, the top pick this week is a randomized trial of intensive glucose control versus standard glycemic control in patients with acute coronary syndromes who present with hyperglycemia. This was a single-center study, randomized trial of about 300 patients. They excluded insulin-dependent diabetics, but included diabetics and non-diabetics who presented with a presenting glucose of between 140 and 288, and randomized them to intensive IV insulin protocol versus standard treatment with oral agents, and sub-Q insulin is needed, and IV insulin if it stayed persistently over 288 in the conventional arm. And what was seen was better glycemic control, not surprisingly, with the IV insulin, but there was no difference in the primary endpoint of infarct size evolving from that acute coronary syndrome measured with troponin or CK-MB or by scintigraphy. And then, interestingly, there was a higher risk of major adverse cardiac events. And so death or MI was significantly higher. It was just 8 versus 1 events, but that was 5.7 versus 0.7 and a p-value of 0.04. And so this has been seen in other settings in the peri-surgery setting, but here in an acute coronary syndrome setting, outcomes were actually worse in this small study. And so this reaffirms the shift in the guidelines away from intensive control and aiming for moderate control of glycemia in the ACS setting. So for this week's Cardiology News on CardioSource, I'm Chris Cannon.